So since we are on the record, I welcome once again everybody who's in my class right now and everybody who's listening to this. Like I say always, this is just 1 hour of quick revision, just the essential points which you cannot do without for your exams. And this particular part, the OCPs, part 2 of contraception, which I'm going to take. The earlier class was basically a conceptual basic class in which I spoke about, certain fertility awareness methods and barrier contraceptives. Even that is very important. And now, from now onwards, I'll be discussing those topics which are heavily asked in exams. All right. So in this, just my attempt is just in this 1 hour to give you all those questions, answers which are asked in your theory and Viva both. So if you attend this 1 hour class with me, I'm sure if you already know the topics will get embossed in your mind. And if just in case you've not read, you're still planning on reading, this will give you the perspective, how to go about it, what to read, what not to read. Because a lot is given in your books, all your books, I'm sure. Like I recommend Nevja Goel a lot for contraception. It's a complete, concise book that's pretty nice, given to you. So, and it's basically written by an Indian author, so it's very easy for you to, produce it in your examination. Okay. Otherwise, of course, all your basic books are doing a good job to teach you the contraception, and I'm going to do maybe one step further in making you understand all the important things I've tried to pull in from everywhere which are asked in contraception. If I were the examiner in the especially in your practicals, my emphasis will be a lot on how to prescribe the pill, which day to prescribe the pill on, what should be done if the patient misses the pill, what if she misses 2 pills in the first period, in the first week, in the second week. That will be my emphasis. And also I'll be asking you the latest brands of OCPs available, what are the first generation, what are the second generation, which progesterone is there in Drones, which progesterone is there in Yasmin, what about Diane. And that answers, all those answers I've tried to pull in and put in my PPT today. Also, it's going to be a very, very interactive session. So this PPT I will give as a present to that student. I'll just take one of the students who answers the best and who's the most interactive in the class. So that's going to be the stimulus for you all to participate in the discussion, participate freely, answer a lot, so that you learn from both the correct answers and the mistakes. I hope you all know how to handle the chat box in this app, this Telegram. So just go ahead and then leave a comment. Just click on that. You'll enter the chat box and you can write whatever you feel like as the answer for the question that was asked. So without wasting any further time, let's begin with understanding the part of contraceptive pills, which we call the pill. Okay. So like I said, oral contraceptives, they are called the pill, and they are basically called because they are very small, pills which are taken, and this is the word which we use for, the OCPs. Now, there are 3 types of pills which we use, okay? One is the combination pill, which I'm going to talk about in detail tonight. Then there is a sequential regimen, to a certain extent used, yes, in which the estrogens are given for the first 16 days, which, kind of mimic like a normal period. And then the progesterones are added towards the last 5 to 6 days, okay? And then you have a progesterone-only pill, which I'm not going to discuss in this topic because it's a OCPs, basically contraceptive pills, okay, oral contraceptives. So yes, they are progesterone-only pill is also a part of OCPs, but not COCPs. It's a combined oral contraceptive pill, both basically that I'm going to be taking. Also tonight, I'll be touching upon the most important part that you all are, kind of dreading, that is medical eligibility criteria, which is so easy to understand. You yourself will be able to answer tonight's class. All right. So just be with me and you'll be able to understand how to go about it. So what is now the generation of these pills? So you have a first generation, second generation, third generation, fourth generation, and mind you, all these are decided on the basis of the dose of ethinyl estradiol and the content, which is progesterone. So we're discussing basically the combined oral contraceptive pills. Okay, combined, that means I'm talking about estrogen and I'm talking about progesterone. Now, let me clear this right from the beginning, that as far as the estrogen content is concerned, it is only and only ethinyl estradiol. No, but let nobody confuse you there. Okay. It's always and always ethyl estradiol. There was a content earlier on which was, still in marketing phase and it was trial phase, but then it got lost in between. And now we only use ethyl estradiol, the dosage of which I'll tell you again right in the beginning so that there's no further confusion. It was used earlier on as 50. Okay, now 50 microgram, you know that it's notorious for causing and being linked with venous thromboembolic episodes, venous thromboembolism, and you'll be studying more in detail when, in the class to come. So the dosage was heavily reduced from 50 to 30 and then to 20. Some nowadays even use 15. But again, it's used, it's associated with a lot of breakthrough bleeding and erratic periods, and then of course escape ovulation, which we are all kind of dreading of. So such high dose from 50, and now we are basically kind of hovering around 30 and 20 dose. Even the leading, pills these days, they have 20 or 30 to be more safe. Even 35 was being used, and now mostly we are kind of covering 20, 30, even 35 is being used. So as far as the estrogen component is concerned, this is the only variation, permutation, combination, if at all. It's going to remain the same. The salt remains ethyl estradiol, but the dosage might change. And that also, I'm telling you, is pretty constant these days. It's mostly 20 and 30 at the max. So just in case an examination do forget about a particular thing's dose, or you're not able to remember, always say ethyl estradiol 20 to 30 milligram. Just in case somebody's trying to question more, just say 30. Mostly it's the safest bet. So first generation, second generation, third generation, fourth generation, mostly they are because of the change in the progesterone content and the salt that is being used. Okay. So we had earlier on, the oral contraceptives in which the old generation progesterone was used, that is norethindrone acetate. Okay, or linestrol. These were very first generation progesterone, and they were with a lot of side effects and stuff. So now they are rarely used. So that's the first generation. Just remember the salts name: norethindrone acetate, NEA as we call it usually, and linestrol. Okay, ethynodol, whatever. It was hardly used. Second generation is your levonorgestrel, mostly levonorgestrel and D-levonorgestrel. So what all OCPs do you remember of them? Mostly Mala N and Mala D. So Mala N happens to be levonorgestrel, and D happens to be the D-levonorgestrel is there in Mala D, as the name says. Then we come to the third generation OCPs, which have the content of the third generation is norgestimate, desogestrel, progestogens, and gestodine. So these, you heard about Femilon, Novilon. They were marketed a lot at that time when we were students. And that time, third generation had come. So third generation was these. So desogestrel was there, gestodine was there, norgestimate, NGM we used to write down, norgestimate. And these were mostly there in Femilon, Novilon, okay, even in Loet. They're also in minis. Now just look at the dose of minis. In this third, only 15 microgram ethyl estradiol. We do not market it in India. It's not there. But all the others are. Femilon, Loet, Novilon is there. And then we speak a little more about the newer generation, the fourth generation, because this is a question that can be asked not only for your contraception, but also as a recent advances or a fourth paper question that just describe in detail the fourth generation pills. So estrogen content is the same. Ethyl estradiol is there. The content, that means it's going to be around 20, 25, 30. And progestogen component is changed. What is it now? It's drosperinone. Desogestrel was there. In the third generation, drosperinone, you have dinogest, and you have nestrolon and nomigestrol. Okay. So you've heard about, this drosperinone. It's there in Dronis. It's there in Yasmin. What about dinogest? Dinogest, you have free days is there in which there is dinogest, and then there is nestrolon. I've not seen much, and nomigestrol same. Nomigestrol again not heard much. So fourth generation of pills in India, they contain ethyl estradiol, like I always say, and then usually this drosperinone, which is actually weak anti-mineralocorticoid activity, and it's useful in patients with PCOS. So Yasmin, Dronis, they are the ones which do not let them cause weight gain. So you require a contraceptive to regularize the cycles in patients with PCOS. And at the same time, you want such a component in which they do not have the ugly side effects of all the pills. So you go ahead with giving them these, drospirenone containing pills so that they do not have weight gain. In fact, they say it might lose some weight because of its anti-mineralocorticoid activity. So instead of gaining the, retaining the water, it makes them lose it. It makes the skin smooth. They may look better. And then you have one more thing coming up, which is cyprotron acetate. Cyprotron acetate is another progesterone congener along with ethinyl estradiol, and that's the main component of crimson and Diane and all that we used to use before. So that's useful in patients with acne, hirsutism, because they say that it's got a weak anti-androgenic activity. That I was about to tell you, which is also equally important because that might be asked again. So what is the cyprotron content? This is a little slide that I've tried to making a little easy to remember. So you see here the generations, 50, this is the first, second, and third, fourth generation. You see the component, the dose of estrogen, ethinyl estradiol, that's continuously decreasing. So you see that the third and fourth generation, which will be asked in your examination mostly, and which will be asked even in your Viva mostly, that is there in the last slot. That means it's 20 to 30. Minis, it's not marketed in India. We do not. Have you ever seen anybody give minis? It's got only 15 microgram. Let's not talk about it. So mostly they have ethinyl estradiol as 20 to 30. So that's where we're sticking on now. And then, like I said, norgestimate is there in third generation. Norgestimate, desogestrel, gestodine, and then femilon, novilon, loet. Fourth generation, we have drospirenone, dinogest, nestrolon, norbigestrol, and then you have Yasmin and Jonas mostly.